12:02. I want to make sure we have the most amount of time. So thank you for joining us today. It's really exciting to have our Roy Ball speaker series pick up again. And today I have the great pleasure of introducing Cynthia Dougherty, who is the Spence Endowed Professor of Nursing at the University of Washington School of Nursing. She's also Adjunct Professor in the Department of Medicine, the Division of Cardiology, and an adult nurse practitioner in cardiology at the VA Puget Sound Healthcare System in Seattle, Washington. Dr. Dougherty is a nationally and internationally recognized expert on recovery of physical functioning, psychological adjustment, and quality of life in persons who have suffered sudden cardiac arrest and have received an ICD, or when your defibrillator goes off because you're having an abnormal heart rhythm. She has conducted trailblazing research and exercise after ICD, caregiving interventions after ICD implantation, and goals of care communication in advanced heart failure. She leads a large interdisciplinary team building a program of research that began by systematically characterizing the experiences of those who survived cardiac arrest in Seattle, Washington, the home of pioneering work in resuscitation science. She is the author of over 100 publications and $20 million in research funding. You can tell from this description, there's a lot of shared interest between her work and the work that our Columbia Roybal Center seeks to inspire. And with that, I'm going to pass the mic to Dr. Dougherty.
Good morning, everyone, and thank you for this wonderful opportunity to talk with you about exciting work that we're engaged in right now, and hopefully we'll stimulate some interest from all of you in the same area. So what I'm going to do is share my screen, and as I had spoken earlier with Ian, there's two important times that I've left open for questions. And so I'm going to talk a little bit about PTSD and ICD shocks first, and then second, share with you our current research that we hope is going to get NIH funding in a couple of months. And then also feel free to raise other issues and questions as we go along, but if you're able to, just hold them for the times that are set aside for question and answer. So today I'm going to be talking about the prevention of PTSD after an ICD shock. Let's see here. What I thought I would do today is start out with some cases, talk a little bit about the defibrillator and defibrillator shocks, the definition of PTSD, and how PTSD is prevalent in cardiac disease, specifically in those with defibrillators, the recognition and treatment of PTSD in our ongoing work, and then hopefully leave you with some pearls at the end of the discussion. So I'm going to start out with two cases, and there's a lot of details in the case. And as I was speaking earlier with Ian, I'm not sure how much of this is really going to be relevant to all of you, but I'd like you to get an idea of the two patients that I'm going to talk about today. So our first person is a 57-year-old male who came in for a cholecystectomy back in 2020 and had some atrial flutter that was noted there, and had an ablation for atrial flutter. And then during the cholecystectomy, he had noted ventricular tachycardia that caused hypotension during the procedure. He had an EP study and went on to have a defibrillator implant. His past medical history is listed here, and I don't want to read all of this to you, but you can scan through some of the issues and problems that the person has experienced before. And what happened was he experienced an ICD shock 2 in a row, one right after the other, well, after he'd been playing golf, but he's actually sitting in his car. He felt dizzy. He got one shock that was quickly followed by a second shock just a few seconds later. And on ICD interrogation, he had monomorphic VT at a rate of 255. The ATP failed. His first shock caused a secondary break, but VT returned in 8 seconds, and then the second shock was successful. He called 911 from his car, taken to the hospital. They started amiodarone, had an angiogram, has mild CAD, no ischemic targets, and no electrolyte abnormalities. Case number 2, a 45-year-old male with congenital heart disease. He had his first ICD implanted for VF cardiac arrest following the stress test. Had a generator change out later, had an open heart surgery for AVR, has a bioprosthetic valve. He had COVID in 2021, and he recovered from that. He has a past history of hypertension, EF in the 25% range. He uses marijuana on a monthly basis. And in Washington, marijuana is not considered an illicit substance. So both, the smokable products and edible products are available. His first ICD shock happened when he was just walking in a store. He was looking for a new television. He got dizzy and it was followed by an ICD shock. And so what he did was he backed up against the wall and just sat down up against the wall. His wife went for the car. They drove him to the local clinic on ICD interrogation, monomorphic VT, 239, ATP failed. One shock was successful. His labs were normal in the clinic. On interrogation, prior interrogations, he's had shown to have 87 episodes of non-sustained VT in the high range. Heart rate's 166 to 189. He was not interested in beta blocker therapy at that time because it caused minor dizziness while he was on the medication. So an implantable defibrillator is used for the treatment of cardiac arrest for VT, VF. It comes with rapid pacing and ICD shocks. That is in the transvenous version on the upper right. The subcutaneous version on the lower right does not have ATP or pacing capabilities. The ICD is implanted for primary and secondary prevention, about 150,000 new implants in the US each year. And ICD shocks are a unique experience of cardiac patients. Primary prevention, about 5%, 8 to 12%, and secondary prevention. And there's, again, about 150,000 people a year getting ICD shocks. And the risk for getting shock are listed here. Low ejection fraction, not on a beta blocker, and so forth. And history of VT, those are at highest risk. So the shock experience is variable across patients. It usually comes on without warning. There can be more than one shock delivered in a sequence. The shock intensity is painful, 7.5 to 8 on a 0 to 10 scale. And it feels like getting kicked in the chest by a horse, somebody hitting you in the back with a hammer. I just had a patient that was shocked a couple days ago for AFib with RVR, and he thought that his neighbor had pulled out a shotgun and shot him in the back while he was out planting some garlic in his yard. It usually causes surprise. People are unsure what to do. They're for a few seconds not sure what happened. There may be some syncopal symptoms before the shock, and some people will pass out. The muscular contractions that are caused by the shock can cause people to fall to the ground, and some of them can be injured. We hope that our people are anticoagulated, that doesn't happen to them. We don't want them to pass out. We don't want them to fall to the ground. After they get a shock, they can feel dizzy, unsteady, they're fearful, they have anxiety, some have panic reactions, but most people are kind of sitting there wondering what happened and now what should I do? Oftentimes after a shock, people believe their heart condition has worsened. They can experience severe anxiety, depression, hypervigilance, and activity avoidance. So what is PTSD? The DSM criteria, DSM-5 criteria, defines it as exposure to actual or a threat of death, serious injury, or sexual violence in one of the following ways. Either you directly experience the event, you can witness that event, and this can be how bystanders develop PTSD. You can develop PTSD yourself by learning about the traumatic event that's occurred in someone else, or experiencing repeated and extreme exposure to aversive events, for example, in catastrophic episodes that happen in the environment, mass shootings, earthquakes, and that sort of thing. The diagnosis requires all of the following to occur at least for 1 month. You have to have one re-experiencing symptom, one avoidance symptom, 2 arousal and reactivity symptoms, and 2 cognitive or mood symptoms. And the symptoms have to cause significant distress, and the symptoms cannot be attributable to a physical illness or to a substance. So in the re-experiencing symptoms, you have to have any one of these. In avoidance, any one of these. Arousal and reactivity, 2 of these. And oftentimes arousal and reactivity symptoms are the things that bring the patient to our attention. And you have to have 2 cognitive or mood symptoms, any one of these 2. And these all have to fall together in a cluster for at least 30 days. So the prevalence of PTSD after an ICD it's reported in the literature. It's variable between 20 and 40%. Some reports show that PTSD symptoms are reduced over time, while others report an increase in PTSD prevalence the longer that you have a defibrillator in place. So here are risk factors for PTSD in people who have ICD. So if you're a woman, if you're younger, if you have a history of childhood trauma, if you already have a psychiatric disorder, low social support, if you happen to have shock storm, poor understanding of the device and the cardiac condition, and more advanced medical illnesses all put people at risk for developing PTSD after they receive a defibrillator. So why do we care so much about mental health concerns in cardiac patients? Is because PTSD is related to lower quality of life, higher mortality. We want to be able to identify and treat and prevent distress in patients with a defibrillator. And this includes providing comprehensive high quality care. And ICD shock is a unique experience of this group of cardiac patients. There's also resilience factors promoted in the literature that prevent the development of PTSD in those who have optimism, those who have good social support or seek social support, those who are equipped with positive coping strategies, they're well informed about their condition, they have an active lifestyle, work, and recreation. And this is Sam Sears. Some of you might be familiar with Sam, is a clinical psychologist at East Carolina University. He and I are strong collaborators on this work, and I'll talk a little bit more about Sam's work in a minute. But he describes survivorship thinking and victimhood thinking that can result in poor coping and PTSD in patients. And I will just direct you to a publication I'll share with you later in helping you think about survivorship thinking in your patients and family members. There are a number of traumatic events that can occur in a person's experience after they get an ICD, all the way from they experience cardiac arrest themselves, or they witness cardiac arrest in someone, they're diagnosed with a serious heart condition, they get a defibrillator, they get shocked, or they may even get multiple shocks. So there are many opportunities that a person with a defibrillator may experience that can lead to the development of PTSD. Now, how do people present who have a defibrillator, and what PTSD symptoms are you likely to spot and hear about? And I've organized these according to the 5 areas of PTSD symptoms that need to be present for the diagnosis. So people talk about phantom shocks when a person has had a shock prior, and they may wake up in the middle of the night and think they've been shocked. And when you do an ICD interrogation, there's been no shock. They obsessively think about it. Exposure to that same event where they got a shock before can have them re-experience the whole event of getting shocked. Like if you got shocked while you're golfing, or you got shocked while you're shopping, when you go golfing again, you get kind of freaked out about golfing. They may have heart racing, and that causes them to feel and be concerned that they might get shocked. They may avoid activities that raise the heart rate because they're afraid of getting shocked. They stay at home. They don't move around. Some are not willing to leave their house for periods of time after they get shocked. They don't like discussing the event. They don't necessarily like to seek health care. They can have hypervigilance around what Sam always calls cardiac metrics. They may be obsessively monitoring blood pressure and pulse, and they might be, reporting this to you every day or several times a day, wanting you to reassure them. They may wake up at night, they can't sleep because they're worried about getting shocked, and they're irritable. They have exacerbated anger and startle responses. So what are some of the general treatments for PTSD? And these are not necessarily treatments that have been tried for PTSD in cardiac populations. Cognitive behavioral therapy, psychotherapy, and medications are sort of our mainstay. And under cognitive behavioral therapy, it's traditionally a 6 to 12 week program, 1 hour sessions. You can also has been reported cognitive restructuring, stress management, relaxation, deep breathing exercises, exercise, EMDR, early use of propranolol after traumatic exposures are all reported in the literature. Looks like I should have that propranolol one down underneath the other heading. Anyway, psychotherapy for PTSD is a mainstay, as well as medications, both antidepressants and anxiolytics. And here's the categories of medicines that are often used. So now I'm going to switch over and talk a little bit about ICD specific treatments. And I'm going to run through this rapidly, but you can look back over these reports to see what in our field has been done to address PTSD in ICD populations. So Dr. Sears, pictured up here on the upper right, Sam Sears, developed an ICD and shock stress management program about 12, 13 years ago, where he compared a 6-week stress management program delivered by telephone or a half-day workshop specifically for people who had received an ICD shock. It's a pre-post design of 30 patients that completed the interventions after receiving at least one shock. On average, the people were in their 60s, primarily male and Caucasians. And what he found was that state trait anxiety was reduced in both groups, whether you did the 6-week stress management program or you did the half-day workshop. More rapid reduction was noted in the telephone sessions compared to the in-person workshop. Both formats increased mental health, and salivary cortisol was reduced and TNF-alpha was unchanged. Sam has also been involved in a CBT intervention for psychological adaptation after an ICD, and this was done with colleagues in Canada. And CBT was specific to patients with an ICD to facilitate adjustment and reduce anxiety and depression related to ICD shocks. And I listed here what they talked about in CBT. This was a randomized trial of 193 patients that either got CBT or usual care and had 12-month follow-up after initial ICD, on average 64-year-old males that got secondary prevention ICDs. 30% got shocks over 12 months, 7% had shock storm. And they had 8 telephone sessions with the counselor, a booklet, and stress management exercises. Unfortunately, the program showed no impact on anxiety or depression. PTSD symptoms overall were reduced. Unfortunately, PTSD symptoms were not, the CBT had no effect specifically in those who got a defibrillator shock. And then there's been another program that was designed and tested in Germany, and this is a really extensive program for the treatment of PTSD that develops in people who had received multiple shocks. And this is a program that was designed as an inpatient rehabilitation psychiatric intervention for people after they had already developed PTSD, and they became inpatients. 18 patients did this who had multiple shocks in their average age in their 60s. They were inpatients for PTSD treatment for 8 to 20 days. And they had 4 to 5 times a week psychotherapy, they had relaxation training, they had cardiac rehab. And they had a bunch of these other therapies that went on as inpatients. 83% reported reduced anxiety and depression. None reported symptoms of PTSD after inpatient treatment, but some took several months to adjust to a satisfactory lifestyle after treatment. And really in the US, inpatient treatment for PTSD is extensive, as this is not probably practical. And then finally, Sears and one of his PhD students, Dr. Ford, developed an ICD trauma intervention to treat PTSD with a web-based intervention after it had developed in 46 patients. Patients were enrolled if the PCL5, maybe that was the S, this is before DSM-5, the PCLS cutoff greater than 30, they entered 43 people into this pre-post design. They had something called ICD TIPS intervention. That's a web-based treatment module. They had all these treatments going on, and their outcomes were depression, anxiety, patient acceptance, and the FSAS ICD shock anxiety scale. Now, this is what happened in the web-based treatment. 46 were enrolled, but only 23 completed all the modules. 12 did not start the intervention at all. 34 did one module, 31 did two modules, and 23 did 3 or 4 modules. So I'm not sure what was going on with the modules, but they didn't have a high level of completers. These were younger people, primarily female. Cardiac arrest was 50% of the sample. PTSD symptoms were reduced by 8 mean points, but did not drop below the cutoff for the diagnosis of PTSD. Unfortunately, anxiety and depression were not impacted significantly, but patient acceptance of the ICD did increase significantly. So my scientific premise is that in all of that summary, we have one small non-randomized study after ICD shock to reduce anxiety. It reduced anxiety and improved mental health in 30 patients. A randomized trial of CBT versus usual care in a couple hundred patients, not quite 200, to reduce anxiety and depression after a shock did reduce symptoms overall, but not in those who got shocked. 2 small randomized studies, 23 and 18 patients already developed PTSD, had significant reduction in symptoms in both. PTSD resolution in 1 within those with shock storm. ICD shock is often a significant contributor to PTSD symptoms, but it's not absolutely necessary to have a shock to develop PTSD in people who have a defibrillator. And then one randomized trial conducted was not designed to treat PTSD symptoms. It did reduce anxiety and depressions. And so my conclusion is no investigations have addressed the early post-ICD shock period to prevent PTSD symptoms in patients with defibrillators who receive a shock. So I want to stop here now for just a couple minutes and see if there's any questions at all about that material, because what I'm going to turn to next is the development and testing of our intervention program that we have, hopefully we might get some funding for. Maybe Heather.
Hi, I just had a quick question. Thank you for that summary. I'm wondering, the 2019 article by Ford, was it a group-based intervention?
No, it's an online intervention called ICD TIPS. And
Okay.
so people are identified, and then they get on this four web-based treatment modules that take about an hour to complete. It's sort of a self-paced thing.
Okay,
But
thank you.
and I think they had coaching with it, but I'm not exactly sure. I think they did. Yeah.
Thanks so much. I just find clinically, we've done a few groups where we've had ICD patients who've had multiple shocks, and the group-based tends to trigger the others if someone has had new shocks. So I just wondered whether that one might have explained some of the null findings, but anyways, thank you.
No, I think the problem with this study is that only half of the people did the intervention, and only 23 actually received the intervention as intended, and 12 didn't even try it. So I think that's the problem in the results. And it wasn't a randomized study, so I think that their results are for those who completed. And half of the people didn't receive it. Okay.
I'll just briefly editorialize, Cynthia. I mean, one of the biggest challenges we've had in this theme of research is exactly that question: is how do you engage people in interventions when avoidance is so much part of the symptomatology?
Yeah.
And so we have not solved that issue just yet, except it's a little bit we know when our patients get really feeling connected with the whether it's resource coordinators or other members of the team, that's sort of following them and develop that trust. And we've had better engagement in their interventions, but that requires a lot of engagement even during their initial hospital stay to develop that trust. But be curious to hear your thoughts on that later on in the talk.
Yeah, I'll actually talk about that because what I always do in any study that I do is I always do an exit interview, and I don't pay anybody till they do the exit interview. And I ask them a lot of questions about, why did you sign up? What interested you? Did we reach you soon enough? So I have some information about that, and I'll show you what happened with our pilot study that started 2 months into the COVID lockdown. So anyway, I have some information on that. I think there's one other question, or is this for now, or do you want to hold?
Yeah, I can hold. It seems like you're gonna talk about my question very soon.
Okay.
So I can come back.
Okay, good. Well, there should be plenty of time for discussion. And I did put quite a bit in here about the development of the intervention. And if you just want to raise your hand and say, we're not interested in that, move quickly, I'm happy to move quickly through that if that doesn't interest the group. Anyway, so what I want to talk now about our pilot study was self-management to prevent PTSD after an ICD shock. This had internal funding in our School of Nursing, a $25 internal grant, and we just received a score of 16. So we're hoping that the R21 will be funded in the next couple of months. Here are our collaborators. Elaine Thompson is my long collaborator at UW. Dr. Peter Kudenchuk is the EP electrophysiologist I've been working with like some 30 odd years. Here's Sam Sears, East Carolina University, and Doug Zatzik is a psychiatrist in Harborview Medical Center and our trauma center. And he and I have been working together, I don't know, several years. We're so excited to see maybe we'll actually get some money to do this study. So the aims of the study were to assess feasibility, acceptability, and usability and safety of the heart rate monitoring in the first month after an ICD shock, and to describe the effects of the intervention on ICD shock anxiety, physical activity, PTSD symptoms, self-regulation, and cortisol levels after intervention completion. So this is a single group pre-post-test pilot study testing our heart rate self-management intervention that starts within 1 week after receiving a shock. We enrolled 10 patients. Heart rate monitoring was done for 4 weeks. The interventions were delivered in the first month after an ICD shock, which is the critically vulnerable period in which the window, I believe, is open for intervention. And also remember that PTSD must be present for at least 30 days with 5 levels of symptoms. And so that's why this 30-day window, in my view, after a shock is so important. We took measures at baseline in 1 month. All participants participated in an open-ended interview at the end, and we measured cortisol in hair and saliva. So the inclusion criteria was you had to have an ICD implant for preventing cardiac arrest. You had to receive a shock within the week prior to study enrollment. You had to speak English, and you had to have access to a mobile phone or a computer for the 30-day duration of the study. You're excluded if you had prior mental health diagnoses or any other prior diagnosis of PTSD, because we're trying to prevent PTSD, not to treat it. You had to have if you had a short blessed cognitive screening score above 6, you couldn't be in the study because this is a social cognitive theory intervention. You have to have a certain level of cognition present to be able to participate. You had to be an adult over 18. If you were drinking a lot of alcohol with a score of 4 or higher, could not be in the study, or if you're using illicit substances. And again, as I said, in Washington, that does not include marijuana. So what we did was we chose a social cognitive theory of self-regulation to design this intervention. And we have in the past used Bandera's social cognitive theory intervention. And some of you might be familiar with the social cognitive theory of self-regulation is slightly different than just the self-efficacy and outcome expectation theoretical framework that Bandera has. And I can show you the comparison later if you're interested. I have a slide on that, but if you're not, this paper really helped us think about how we could design this intervention. And self-regulation of behavior operates through 3 sub-functions, according to the theory: self-monitoring, self-judgment, and self-evaluation. And the SCT of self-regulation has been shown to improve outcomes in chronic illness conditions. And using these 3 strategies, monitoring, judgment, and evaluation, that is supposedly leads to an improvement in self-efficacy, or the confidence to perform health behaviors on your own behalf. So I'll show you a little bit more how we connected the intervention to these 3 areas. So self-monitoring, self-judgment, and self-evaluation include these specific details. So for self-monitoring, feedback, you have to have feedback on a behavior in order to change a behavior. It has to occur close in time to the behavior you're hoping to impact. You have to monitor regularly. You can't do intermittent monitoring. You have to have consistency in feedback. You have to focus on success. You have to monitor important behaviors that are important to the person and important to the process. People have to be motivated, and the whole goal of self-monitoring is for the person to gain insight into how that behavior should inform what they're doing. Self-judgment is that you can have other people give you feedback. You compare yourself to your own progress. You evaluate progress compared to normative data, and you provide examples of success. And self-evaluation is that you gain confidence. This is how you turn self-regulation into self-efficacy. When you do these things, you gain confidence, you monitor your data, and that gives you direct feedback on how you're doing so that you feel like you can go forward. You set personal rewards and goals. So these are the ways that we designed the heart rate self-monitoring intervention to address these 3 areas of the theory. So heart rate self-monitoring intervention, we have the people wear a polar heart rate M200 monitor 24/7 for 1 month. So we gave them the watch. And this is an optical wristband with a heart rate monitor that records heart rate during activity. It also gives you steps and minutes, and it shows heart rate on the watch. Right here is the heart rate that it shows on the watch. It gives real-time feedback on heart rate for normal activities of daily living. It also, you have access to what's called the Polar Flow service, which is a free service where the person can upload their data onto a Polar Flow account. And this can be viewed on your phone. It can also be viewed by me, by the investigator. So the patient shares their data on the Polar Flow service. It records sleep hours and quality ratings. You download it and charge it every week, and it can hold 7 days of activity and data in the watch. The heart rate self-monitoring intervention was coupled with heart rate education, where we gave people feedback on their ICD cutoffs, and we recommended that they keep their heart rate below 20 beats a minute below the cutoff for a shock at all times. How do they do that? They look down at their watch and they see what their heart rate is. And if it's getting within 20 beats a minute of a shock, they slow down, or they deep breathe, or they step back for a minute. We also gave them a walking program with heart rate monitoring and GPS tracking, which this watch does. And we had them practice deep breathing exercises while they're doing heart rate self-monitoring. And so the theory is that real-time monitoring and feedback of an important sign, which is heart rate. Heart rate is the sign that we monitored. It varies over time, but patterns will be established in heart rate that can be discovered by the patient. They gain insight into the effects of their own behavior on heart rate, and they monitor it constantly for 30 days. And they begin to understand that even if they run up the stairs, even if they get mad at someone, even if they go out and walk, or even if they deep breathe, their heart rate is not going to get anywhere near the shocking zone. So they are safe to perform activities of daily living that they normally had done before, and now they're afraid to do. So this is the theoretical framework, and this is the intervention. Here is our walking program, and if they're not exercising regularly, they started walking on using the left light blue column. And if they were exercising regularly, they used a walking program on the right hand side of the slide. And we prescribed exercise and had them wear their heart rate monitor for all activities. And then they download the information and we discuss with them their responses to walking. We also did this with our calm breath protocol. And this is a calm breathing protocol that's out in the literature, where this person is demonstrating what the calm breath exercise is, where they're breathing with their abdomen slowly in and out to a count of 5, and inhaling and then exhaling. And we have them practice the calm breath exercise while they're either sitting up or lying down with their heart rate monitor on, and they watch their heart rate monitor the whole time they're doing the breathing exercise. So they learn that as they're doing deep breathing, their heart rate goes down. So they have a hip pocket strategy for reducing their heart rate if they're getting freaked out or they're getting scared, and they know their body's response to the breathing protocol. So they practice this with their monitor on. We also developed these modules that are called self-paced self-management modules. And there's 4 modules, but we did not test this in the pilot study. We developed these, which focus on gaining information, assisting with physical and psychological symptoms, returning to ADLs with physical activity, and creating positive cognitions. The modules take about 20 minutes to complete. We did not test this, but these are ready to go. And these were derived from the Sam Sears stress management protocol. And we will be testing the modules with the heart rate self-monitoring protocol together in the R21 if we get funded. Here are outcomes, feasibility and acceptability outcomes. And then I mentioned this, here's our other outcomes in the pilot study. We use the SF36 PCS and MCS scores. For PTSD, we use the PCL 5. I should have changed that to a 5. We're not using the S anymore, sorry. The Florida Shock Anxiety Scale, we monitored physical activity in steps per day and minutes per week. We have a self-regulation measure of self-efficacy and an index of self-regulation. Where did this index of self-regulation come from? We just made it up. We just put the outcome together, and we've only pilot tested it. And that might be something that you have to think about doing. And then we measured salivary and hair cortisol. Salivary cortisol was measured at the beginning and end of the study, and we only used hair at the end. And I'll talk more about the theory behind using salivary cortisol and hair for this study. We wanted a physiologic measure of stress, and we weren't certain people would be willing to cut their hair twice within a month. So we just had them cut their hair one time. And all of these data were collected over telephone, Zoom, or through the mail, because we started data collection in the middle of the Washington State lockdown, which went from March 12th until the end of July of 2020. And then we resumed, you could resume research after that, as long as you had no personal one-on-one contact with subjects. And that went on in our state through March of 21. So I have some funny stories about how we got some of our physiologic measures, if anybody cares about that, but it was not easy, let me just say. Okay, our results: 10 subjects on age 58 years old, age range from 33 to 71, all were male, primarily Caucasian, recruited from the VA Seattle and UW Medical Center. People were primarily employed, and their education is listed here. Finished vocational college, 2-year degree, 4-year degree, graduate degree. And I would say on average, people had a significant household income. 60% had greater than $70,000 annual household income per year. On the Charleston comorbidity scale, on average, they had 2 other comorbidities. Their BMI was, 28 or so, not overweight, but not skinny. The indication for the defibrillator was secondary prevention. Mostly they'd had, and this surprised me, people, 50% of the people in the sample had a prior shock. The alcohol use scale was a little bit high. It was higher than I thought it was going to be, but it didn't exceed 4, and none were using other substances because that was the exclusion criteria in the study. So here's what we found. So on the physical and mental health scale, really no change in physical health, improvement in mental health, but it didn't reach statistical significance. We noted in just 10 people that PTSD symptoms went down significantly, shock anxiety went down significantly, steps per day went up, not statistically significant, percent time inactive stayed about the same, and peak activity index stayed about the same. So we didn't have any impact on that, but a definite trend towards increase in steps per day. Why? Probably because we prescribed it. I mean, we were asked them to do more. Self-efficacy improved, self-management behaviors unchanged, and cortisol really unchanged. And hair cortisol, here's a measure just to kind of give you an idea of, this is how much cortisol we could derive from hair. So the acceptability measures, why did the people join this study? 40% thought there was going to be a benefit. 30% wanted to help others. They wanted heart rate information, or their clinician recommended it. 20% signed up because they wanted their shock concerns addressed. They wanted closer follow-up, and they already knew they had anxiety, so they wanted some treatment for that. The benefits, all of them learned about their heart rate responses. They learned how to do heart rate monitoring, and they learned the importance of heart rate feedback. They were less worried. They got more information about their heart. They learned about the defibrillator, and the study benefits to the, other people were all these things. 10% listed these other things. They liked the coaching. They wanted to do more exercise. They thought the timing was right, and they thought their participation was successful. The difficult parts, majority didn't find the study protocol difficult. It was difficult to get the heart rate monitor charged. So even though the Polar M200 gives you 7 days of battery, that's not the case. So just like some of you might do, I always try my own study protocol on myself before I ever ask patients to do it. So I got one of these M200s and learned how to program it myself. I was in Lake Tahoe in the summer and hiked for a week. And so I had my monitor on every single day while I was hiking. And I download my, data at the end of the day. But what I would find is if I wanted to record my heart rate, it would only hold about 4 hours of recording in my watch, and then the watch would go dead. And the reason for that is that if you're recording your heart rate and saving it, the memory runs out, but the GPS, it shows you where you are. And I'll show you some examples of how the watch works. When you use the GPS feature and you're recording a heart rate every 15 seconds, it uses up the memory, and then the monitor dies. So I found when I wanted to use it daily and record, I had to charge the watch every night. It wasn't a big deal, but what was frustrating is that it would go dead halfway through my exercise or my hike. So other patients found that to be the case too. And one person thought it was difficult to meet the walking goals in the study. How should the program be offered in the future? The same format. 50% said definitely you should require this for people who get a shock. 20% wanted more online content. And then another 10% said these were the other key features of the program. Coaching was key. They wanted more contact with me. They wanted more feedback, more communication in different modalities. They wanted text messages. They wanted chats. They wanted Zoom. They wanted more email. our IRB did not approve that. And so we didn't offer all these modalities in the middle of this study. And what other ideas do they have? So whenever I have an exit interview, I say, well, if not this program, what would you like? What would you like instead of this? What could we do in addition to this? So this is what they said. Well, 40% said if a chat room had been available, they would have participated in it with other shock patients. 40% wanted more ICD shock information, how to use their medications to exercise safely. They wanted more information about heart rate, and they want more coaching. And 10% wanted a different heart rate monitor that was more sophisticated. They pointed out to me that I used the cheapest, easiest model, and they wanted a more sophisticated model. How come we're not using the Apple Watch? Well, the Apple Watch is, $650, and my little grant funding didn't have that. It had enough money for $100 watch, and that was it. They wanted telephone help. They wanted a group exercise set up where they could meet other people who got a shock and could go walk with them, and everybody could do heart rate monitoring together. And they wanted ideas about where to exercise safely. So let's go back to our cases, and then I'm going to wrap this up. So our 57-year-old male who got a shock after golfing, and this is just a review. Here's his ICD programming and his risk factors for PTSD. So in the study, his activities were walking, golfing, and weightlifting, and he was told to keep his heart rate below 160 because at the time, his lowest shock was at 187. He walked during the study 4 days a week. He recorded, he weightlifted, but not until the end of the study. He was too afraid to do that. He felt more comfortable at the end, and then we gave everybody the watch to keep. So everybody got to keep the watch, but we stopped monitoring their heart rate, which they didn't necessarily like. They wanted us to keep watching with them, but we didn't because that was the end. He called 2 months later after he noticed his heart rate in the 130s on his watch. He sent in a home transmission and showed that he was having slower VT that was picked up by the watch. So Polar makes really great products, even cheap products, which I had learned in a prior study. And so amiodarone, he got loaded on amiodarone when he got his initial shock. That can occur, as you all know, that as you treat the arrhythmia, sometimes the arrhythmia doesn't go away, but it pushes the arrhythmia to a lower heart rate that then creates some other issues for you. So then we needed to, do a different heart rate target for him. So here's what it looks like when you go to the Polar Flow Service. And this is 1 month of data from this subject. And you can block out the names, and this can be kept private. So here you see he's recording walking data, and then later he did weightlifting data. So you can program activities in the watch, and then you know what you're actually recording. So here's his data. And here is when he exercised for 10 minutes, 12 minutes, 15 minutes, 12 minutes. He did a perfect protocol in week 1, if you remember our walking protocol. And this is what you get from the watch. This shows where the person walked. But here's the most important part. When he puts the watch on, immediately his heart rate is in the 80s. And throughout this walk, that was 2 o'clock in the afternoon, he went 0.72 miles for 20 minutes. His heart rate stays in the 80s to 90s throughout the entire walk. Here's the speed of his walk. So he starts walking, he stops because he's short of breath, keeps walking, stops, and then he ends. Here is the, this is the uphill. I think this is this is the walk uphill. And then here's his weightlifting heart rate. So you can see that he has some slightly higher heart rates during weightlifting for a total of, looks like maybe 40 minutes he did that, but average heart rate is 80. Here's the sleep data. So here he gets up in the morning and he's awake all day. He goes to sleep about 10 o'clock at night, but he gets up a lot during the night, doesn't have very restful sleep. That's kind of important information. So in case 1, he starts out with anxiety score of 32. It goes down to 19. His PCL score goes from 25 to 16. His steps per day go up by about 2,000 steps a day. Percent time inactive was reduced from 68 to 65%, and the salivary cortisol really unchanged. Here's subject number 2, 45-year-old that got shocked while he's shopping for a TV in a store. And he's younger. Here's his risk for PTSD. During this study, his activities were he walked twice a day. And this is a guy who puts on a 50-pound vest to go walk. And when he goes, I said, no vest. Okay, we're just going to do walking. He does virtual boxing in his house and he swims. We ask him to keep his heart rate below 145. He walked 4 days a week, sometimes more. He did not start boxing until week 3. He was too scared to do that. He sent in his ICD interrogation halfway through because we increased his metoprolol throughout the study. Here's his data again. He's walking and he's doing some other stuff. And I'll tell you what some of these boxing episodes are because, people never really do exactly what you ask them to do. They kind of do what they want, which is what you expect. Here's a walking session where he starts out and he's walking, but his heart rate's up in the 100s when he stops. And then he just abruptly takes his watch off, which I don't want him to do. And I'll tell you more about that later. He starts out walking and he goes pretty fast and then he slows down. He has to stop. He also walks up a hill. This shows you the altitude. Sorry. This shows you the altitude of walking, where they're walking up or down hills. And you can see whether or not the heart rate goes up with going up a hill. It didn't in this case. And this is a boxing time when he starts out boxing according to a game that you play at home. But you can see he gets up into the 140s while he's boxing, and then he comes back down. This is his wake sleep cycle. He's awake throughout the day and he sleeps pretty well at night with few interruptions. So what happened with him? He starts out with anxiety score in the 20s, PCL goes down, steps per day go up, percent time inactive goes down, and his cortisol is unchanged. So the takeaways for me and perhaps for you are to be aware of the risk for shocks and address these as soon as possible. Be aware of your institution's shock rate and have somebody calculate this for you. At UW Medicine, our shock rate per year is about 14%. At the VA, about 11%. And that might be because we have a lot of secondary prevention patients. When you treat patients, keep the risk factors in mind and ask patients about severe anxiety after a shock, even if they don't mention it and even if you don't notice it. Do you feel nervous or jittery? Do you have periods of intense anxiety? Are you awake at night thinking about it? Are you staying home all day? Are you having nightmares or flashbacks? And if yes, to any of those, I immediately start them on some lorazepam to calm the anxiety down right away. I usually give them up to 3 a day, not to exceed a total of 30 for 30 days. And consider suggesting heart rate monitoring and making recommendations for activity. And of course, you can refer to psychiatry. Here's a really good read if you're not familiar with this paper. I recommend you read it, even though it's about a decade old, written by Sam Sears about post-traumatic stress disorder in the defibrillator patients, what you need to know in electrophysiology. So here's our research team. Here's our clinical research team. I've been working with the Portland VA EP team for almost 20 years. Here's our research team members. And I thank you again for inviting me and happy to talk about questions in the last 5 minutes, it looks like. And I'm going to stop share so I can see all of you. Yes. I don't know. Ian, you could call on people because I don't know who put their hand up when.
Well, maybe I'll let Sachin put a comment in and had his hand up before. Sachin, is there any questions that you want to ask or you want to go back to your comment or?
Oh yeah, no, thank you, Ian. And what a pleasure, Cynthia, to see you here. Our group is such a big fan of your work and have been following and citing your work everywhere. Every paper we write, we have to cite your work first. My question was one about the pilot that you presented and the inclusion criteria that a single shock before the enrollment was enough to have them enter into the study.
Yeah.
So you mentioned also that Dr. Sears' work about more than 5 shocks is what it takes to develop PTSD. So what proportion of your population or the sample ended up having PTSD development because it was more like a prevention, early intervention study?
Let me go back to that one slide really quick. And I think our PCL scores were low. So we didn't have anybody over 30. And that's really great. But what we're interested in doing is getting to people before they develop PTSD symptoms. And you don't necessarily have to have 5 shocks or more to develop PTSD. These individuals can go on to develop PTSD anyway. So our mean score at the beginning of this study was 7.5, and they exited at a mean score of 4. But subject number 1 already was at 25 and went down to 16. And subject number 2 that I showed you started out at 19 and went down to 9. So there's people that have severe anxiety right away, and they have quite a few PTSD symptoms, but might not yet reach the DSM-5 diagnostic criteria for that. We want to get to them before they get that. Hopefully.
Gotcha.
Yeah.
Thank you.
Yeah.
Hey, Jeff, do you want to ask your question?
It's a couple things. Yeah, sorry. I'm thinking, well, I'll ask maybe the one that's of more interest to multiple people. So the breathing component, I was interested if you have compliance data on that, or feedback, even anecdotally from patients about the breathing part of it. Many of us here are interested in breathing intervention.
Yeah. So I didn't show you any recordings where, so they recorded. So we have people choose an activity that they do normally. And if they don't have any activities, then we give them a walking program. So you program walking into the watch, you program boxing and whatever. You can't really swim with this watch. And we programmed in breathing. And I didn't show you any breathing exercises, but the way we track compliance with all of that is that they were required to record their heart rate, hit the record button on the watch and save it. So they did the breathing 3 times a week and for 10 minutes each time. And they recorded that on the watch. We didn't have any compliance issues at all. And the reason for that is they knew that I was going to call them on Monday and review their data with them. So there's no data, no walking, no breathing. We had nothing to talk about. So people were highly motivated to be in the study, and there was no issues at all. And you can see from the feedback, they want more. They want to talk more. They want to have more interaction. And some of them signed up just simply because somebody was going to watch their heart rate for a month. We don't do that in clinical practice at all. Now the study offers them that. So they love the breathing exercise. And if you haven't used it yourself and you try it, it's very relaxing and you can fall asleep actually. Breathing. Yeah.
Thank you.
Yeah.
Cynthia, can you talk? There's one other question for, well, I've been talking too much. Al, do you want to ask your question, Al?
Yeah, sure. So I've been interested in like understanding the relationship between diet and health. And your study also focuses a lot on exercise, but I know that, you know, in health has 2 sides of that coin. So I've recently learned that there's a link between someone's eating window, such as like intermittent fasting, and the release of certain hormones like cortisol. And, you know, I realized that you captured some data on cortisol. So I was wondering if you have or are interested in maybe taking a look at your participants' like diet or eating patterns and seeing whether or not that might have any relationship at all with the change in anxiety or PTSD levels, things of that nature.
Yeah, that's a good point. I haven't thought about that, and we haven't been involved in that at all. We hadn't considered it, but you know, we do know that there are lots of things that impact cortisol, and we measured cortisol at 9 o'clock at night, salivary cortisol. They took the sample, put it in their freezer, FedExed it, same day delivery the next day, and we had a little preservative in the cortisol so that you don't lose potency of it. And then I had to go run down those FedEx envelopes and figure out where they were in our university and get them into a freezer within 24 hours after the patient took the sample. So I haven't thought about that, but it's an interesting idea. And could be pursued. There's only so many things you can address. There's only so many things you can try to control, and diet was nothing that we went to. Anyway.
One last question, Cynthia. Do you have any sense of to get your 10 patients, like how representative they might be of the eligible patient population? Like, were a lot of patients approached to get to that number? Were these? Do you have any sense of, were these a very small minority of patients that are highly anxious and wanting to be in these interventions, or were you able to really get a larger percentage of the people involved?
Well, so we approached 18 and we got 10 who said yes. So we were funded to enroll 10, and we didn't have any more money than that. And there was the reason that we weren't able to enroll the other 8 is because I couldn't contact them. I tried, but the other thing we noticed was that if somebody had a shock, went to the emergency room and was admitted, then oftentimes during that admission process, they were not interested in learning about the study while they were being acutely treated for VT. And once there was a treatment algorithm and there was a path forward, they were interested. But by that time, sometimes they were 2 weeks outside of our window. So I had to, I couldn't enroll them, and half the time I couldn't even contact them, or they wouldn't return my phone call. And the minute we heard about a person, I was IRB approved to mail them or email them a brochure. So I dropped a brochure in the mail. I emailed them the brochure. I could contact them by either email, phone, or text. And so I could try 3 times. And after 3 tries, I couldn't contact them again. And after 3 tries, and I would contact them every day. And then on the 3rd one, I'd say, this is the final time I'll be contacting you. I need to talk to you today. If you want to hear about the study, it only takes 5 minutes. And if you say no, it's fine. We're done. We don't have to talk again. And a couple of times on that 3rd time, they would respond. And maybe they were out of the hospital then or something, but I could never enroll anyone in the hospital. They were just too scared. They just wouldn't do it. So anyway, thank you so much for inviting me. And I look forward to any collaborations you'd like to have in the future. I know you got to go. I got to go. I'm 5 minutes late for another meeting. So take care, everyone.
Thank you so much, Cynthia. We really appreciate having you.